Addiction of any sort is exceedingly difficult to overcome, and it manifests in lots of different ways. There's lots of different substances people can be addicted to. But here's what caught my attention. A recent New York Times article looked at one particular approach a growing number of clinics in the US are turning to, and that is paying users of meth to quit, like actually paying them. Interesting. Dr. Sally Satel is a psychiatrist, the medical director of a Methadone Clinic in Washington, and she's here to shed some light on this as a practice and what the data says in terms of its results. Hello there.
Hi, how are you?
How does this approach work? I mean, I'm probably oversimplifying it to say like you're handing someone 20 bucks if they don't use this week. In practice, how does this work?
But you're not oversimplifying it all that much. I mean, that's the basic concept of what we call contingency management. That's the formal name for this intervention, but it's been around for forever. I mean, Skinner, B.F. Skinner, the famous behaviorist, had articulated how learning processes are shaped by consequences, but anyone who's raised a dog or a baby knows that. So in the context of addiction, and especially in the context of stimulant drugs like cocaine or methamphetamine, that we don't have any medications. I work in a methadone clinic, and that's for opioids, heroin, painkillers, fentanyl, and it works very well. It suppresses craving and withdrawal, and those are two of the experiences, that keep people, a big part of why people continue to use, but we have no analogous medications for cocaine or methamphetamine. And what we know from years and years, there's such a robust database on this, is that if you incentivize people not to use drugs, that they will use them less frequently. And in the case
I was going to ask about what's the hypothesis as to why this is effective. And I ask because there would be other incentives like, keeping a job, keeping relationships with your family, avoiding jail time, like all the other things that are in the world of addiction. Those haven't proven to be sufficiently effective. Why does money sometimes work better?
Well, the people who are motivated by the rewards of a job or even the fear of their spouse leaving them, we don't see them in these clinics. So this is for clinical populations, people who've tried everything and still failed. So it works because that is kind of hardwired into brain systems, into our reward systems. Not every person responds, for example, to giving them, let's say, a voucher. This is a common kind of reward, a voucher for a movie or for McDonald's or for gas, this kind of thing. It's true that not every patient does. And in fact, we often see a dose response curve. The greater the incentive, the greater the potency of the reward and then response. But across most studies, people who are offered these contingencies / rewards / incentives, that's all the same word, will control their drug use at about 2 to 4 times the rate of people who are not similarly rewarded.
We talk about behavioral finance on this show a lot. And what's always surprising to me is how a small nudge, and whether it's dollars or loyalty points, can lead to a pretty outsized behavior. What are the dollars that prove to be effective? Like, it's probably not $1 million. You've got efficacy at a much lower dollar ring.
Yeah, you'd be surprised. The researchers are always surprised at, frankly, sometimes how little it takes to get people to respond. But you'd mentioned a job and all these other more so-called pro-social activities. That's why these contingencies can be so helpful, is that they prepare people now to take advantage of these much more momentous kinds of life changes. Because once you do get your drug use under control with the help of incentives, then you can go for the interviews, then you can improve your life in other ways. And then the motivation to stay clean kind of snowballs. And so it's more than just the money or the voucher or the in-kind benefit that has the effect. It's that, and then there's the accrual of all these other positive
Yeah.
reinforcements on top of it.
The virtuous circle.
Yeah.
If you were to give me a number just to anchor to, is it $20 a week? Is it $1,000 a week? I ask because I'm trying to distinguish between the feel good motivation and the no, I can actually pay my rent here.
Right. Yeah. Probably can't pay your rent, but let me tell you what California is doing, because it's the first state that actually has gotten approval from Medicaid to pay to underwrite these vouchers. So it's doing a 24-week outpatient programs, and these are in clinics. They could be all over, the whole state of California, where they give a $10 gift card to Walmart or another chain retailer for $10, and that escalates with successive negative results. What I mean is negative urine screens, yet negative tox screens. So you'll get $10 gift card for your first negative result, and then subsequently $26 per test, with a maximum, this is what you're asking, I guess, of $599 over 24 weeks. So you can't pay your rent, but it helps.
When we think about interventions that improve health outcomes for people, there are many that are like mom and apple pie, no discussion, all good, we can all agree to them. Like, let's ensure there are fruits and vegetables for all people. Great. When it comes to paying someone who is dealing with addiction, there are other things that arise that have people be like a little like nuts about it. And I think a part of that is a cultural bias around drug users and how, surely they should just stop using. It's bad for them, like that kind of overly simplistic thinking. What are some things that need to be navigated to build the clinical case to roll these programs out if clearly they are as effective as they are believed to be?
You have to adopt a strict utilitarian mindset, which is, would you rather have $599 be spent over 6 months than, someone shoplifting? These are all the kinds of trade-offs, because you think of all the activities that addicted folks can be, not all of them, of course, but, as a population, a higher risk of committing these kinds of crimes. And so, ultimately it has a dimension of crime prevention to it.
Sure. I'm sure it's fewer ambulance visits or
fewer
ambulance
ER
trips,
visits, fewer
all the
child
things.
neglect visits, fewer everything.
When you think globally, which are the countries that are the furthest ahead on this, who have been able to adopt a utilitarian way of thinking and haven't so entangled morality and all those other things that might, I don't know, tangle the thinking, I guess?
Well, that's an interesting question, because almost everywhere except Singapore, places like that where you don't want to be caught with a, marijuana seed.
Right.
There's a movement, a harm reduction movement, that is becoming more and more forceful. And to the extent that we're talking about needle exchange for people who inject their drugs, almost very few people really object to that. It's been proven, public health studies have shown over and over, it reduces transmission of HIV. And again, here we are again, because when needle exchange in the 80s did become become established, there was a lot of pushback. But then again, you have to appeal to people's utilitarian sense that it will prevent, these infections, and that's huge. So that's a harm reduction that most reasonable people accept. But now we've moved into a harm reduction. I think there's a backlash now, but for years we've been moving into the California encampment sort of culture, which is frankly the opposite. That's an opposite kind of morality, where in essence we feel that people who use drugs have rights to frankly use what they want and live how they want, but no responsibilities. So if anything, I think that some of the morality is going the other direction. And
Just
we've done
just
both. Pardon me, I'm talking about the same state where California and the West Coast, Seattle, Portland,
yeah.
have these problems. Well, so does Kensington and Philadelphia, a serious one. It's almost like two conflicting strategies at once.
Mm.
And I think the contingency management will win out.
I just before we go here,
Yeah.
we began by talking about meth, and for the reasons that you stated, it's a stimulant. There's a whole lot of dopamine that gets released there, and that's worth something to people whose brains are used to that and need that. As you think about broadening it out to other substances, is there something to be learned about how cash and that particular contingency management approach could work in other areas?
Well, as I said, we have excellent medications for opioids. We have some medications for alcohol. They're okay. Cannabis, I don't believe there's much medication. So yes, I would say with addictions where there are no good medications, that contingency management, it should definitely be the default treatment. And also with like opioid addiction, I think we could enhance it. In a methadone clinic, for example, we use take-home doses as an incentive. If people give us clean samples and they go to group therapy and all this, then we allow them more take-homes to the point where they're taking a month of methadone bottles home, just like anyone would for a blood pressure medication, and you get it refilled. So we use it there too. So it can work in concert with standard strategies as well.
Really interesting. Dr. Sally Satel, thank you so much for joining us today.
Thank you.
Dr. Sally Satel is a medical director, a psychiatrist. She works at a methadone clinic in Washington, and she was here today to talk about this idea of paying people to abstain from meth.